I'm going to talk about brain tumor immunotherapy, clinical trials in general, but specifically focused on brain tumor immunotherapy trials. So these are my disclosures. Although you have research funding from some of these companies, I don't have any stocks or stock options. The current standard of care for glioblastoma really has, evolved. Over the last couple decades. Back in the 70s and 80s, really all we had was radiation, and that was pretty much it up until the mid-90s when we started to have some new things that were FDA approved for this. BCNU wafers, the gliadel wafers, were approved in the mid-90s, and then temozolomide then became into first-line treatment in 2005 after the Stoop paper. And since then, there have been some approvals, bevacizumab, Avastin for recurrent glioblastoma, and the Optune device, the tumor treating fields. Although standard of treatment really still is radiation and temozolomide. These other options, even though they're FDA approved, really haven't been widely adopted. Over the last, actually just 3 or 4 years, there have been 20 cancer immunotherapy drugs that have been FDA approved for various cancers, melanoma, lung cancer, and so forth. So I think there's a lot of promise out there in the cancer area for immunotherapy, but we have yet to have an immunotherapeutic drug approved for glioblastoma. It's a very complicated, heterogeneous disease, and so it's been very difficult to get approvals for that particular drug. With that being said, I do think there is some promise out there in terms of the promise of immunotherapy for this particular disease. So I would just want to start with the case report. This is a 33-year-old right-handed man. He basically presented with new onset seizures and speech aphasia, very typical case that we see quite often at UCLA. This was his lesion. Left temporal lobe tumor, he had speech aphasia. We actually did the whole functional mapping and awake surgery, as Dr. Everson was talking about earlier, and did an en bloc resection, got a gross total resection in this patient. Went on to do standard treatment. Oh, here's the pathology. So it was glioblastoma, then typical, basically very textbook presentation for glioblastoma pathologically. Ki-67 index 25-30%, GFAP positive for EGFR, and MGMT methylated. So even with MGMT methylation, based on the Stoop protocol, average median survival is probably about 24 months at best. So nothing too out of the ordinary there. This was actually before IDH1 was discovered, so we at the time did not know his IDH1 status. He actually turned out to be IDH1 wild type, which is actually the poorer prognostic group. But his post-op treatment consisted of radiation and Temodar, and then he went on to a clinical trial, and at the time he enrolled in our early phase clinical trial of an autologous vaccine made of tumor lysates and dendritic cells. And this is kind of the trial protocol. Patients underwent surgery. After the surgery, we took their tumor tissue, and then we co-cultured the tumor lysate with these dendritic cells that we actually developed from the patient's blood, and then that was injected back into the patients as a vaccine at 0, 14, and 28 days post-op. They then went on to do a standard treatment in addition to this. So one thing, so it was a, interesting case, and actually a case that I remember quite well because his wife was 7 months pregnant at the time that he was diagnosed with this glioblastoma, and he was told he only had a few months to live, and at best a couple years. So he after surgery he recovered well, and he actually had his baby. So he made it to the local news. And one thing we talk about in the glioma field is that sometimes, it's always very heartwarming to get Christmas cards from your patients, but unfortunately you don't see more than maybe 1 or 2 Christmas cards because of the duration of survival. So I got the first Christmas card from him, and this was Brad Jr. At 1 year old, when he was a year old, and actually I also had a baby at about the same time, so it was quite heartwarming. But then I got a 5-year-old Christmas card from Brad Jr. And then 10 years. So Brad Jr. And that the dad, Brad, was doing quite well at 10 years. And then most recently, we just saw him, a few months ago. He's nearing 50 years old now, and he has a 16-year progression-free survival. He's healthier than I am. He's actually a water polo coach and much more in shape. So there are these long-term survivors, and over the years, I have a couple dozen of these now in these trials. So there must be something about Brad and these long-term survivors that allows them to live such a long time. I mean, as many of you may know, this is actually unusual for glioblastomas. This is actually the focus of our research lab at UCLA, trying to figure out how to detect and select for these patients that may actually do quite well with immunotherapies. So when he reached the 5-year point, we actually thought, oh wow, he lived a long time. So we actually looked for certain kind of T-cell responses in his blood. So one of the, we were looking for immune markers, and one of the actually control kind of antigens is CMV. It's actually a viral antigen. And what was interesting in his case was, he actually had a lot of CMV in his tumor. It's actually been reported that this does occur in glioblastomas, but it's really kind of controversial as to whether it's just a bystander or an actual target, or even something that causes the etiology of this. But what was interesting is before therapy, I don't know if you could see, he had 0.19% of his T cells were targeted to CMV. After the vaccine, 4.3% of these T cells in the blood were targeted to CMV. It may seem really small, but if you have 4.3% of your T cells targeting a specific target, that's actually quite significant. And it really, what it shows us is that it does actually suggest that the vaccine was creating an immune response. Whether this was kind of leading to his long-term survival, we actually don't know for sure. Other things we found is that the gene expression signatures, or the molecular profile of the tumor, may correlate to better prognosis with this, immunotherapy. Or nowadays we're finding that for all sorts of therapies. And I think as we move to the world of precision medicine, we're going to have to really save the tumor tissue, analyze the tumor tissue, and then stratify patients based on what the tumor tissue shows. In this particular case, we looked at the whole population of the initial clinical trial cohort, and what we found was that the long-term survivors actually had this, basically mesenchymal profile, and we did gene, and these people, and whereas the proneural group, which many of these are IDH1 mutated, which technically do better. So actually, if you look at the days here, they actually did pretty well. 2,000 days is actually, not bad. But these people, they actually, about half of them continued to live beyond 5 years at the time this was reported, and Brad is actually in this group. And 4 of those 5 are actually still alive today, so that's a part of this 24 people cohort that we have over the years. And, we've also looked at kind of things that make predict response. So oftentimes in immunotherapy, not just with vaccines, but also now with the checkpoint inhibitors and all the other new immunotherapies coming up, you see this increased enhancement after treatment, and then over time it kind of goes away on its own. So it's this, kind of a phenomenon that we call pseudoprogression. So sometimes after treatment, and this also occurs after radiation and after temozolomide, you do see a period of time where things actually look like they get worse before they get better. So with that, there's a lot of work now that we're doing at UCLA in terms of imaging, and trying to determine, what's pseudoprogression and what's real progression, and that's a whole talk in and of itself. But that's actually an area that's quite quite heavily investigated as well. So based on those early phase studies, we did go on to a phase 3 multi-center clinical trial in 331 patients. And I just wanted to give you an update of that trial as of late 2018. So of this trial isn't unblinded yet, but there was a crossover arm. So I must say the majority of people actually got the vaccine at some point, either early or at crossover. So if you just look at the whole intent to treat population, in this trial, there was a 28.2% 3-year survival, which is relatively good for glioblastoma. I remember when I was a resident, 3-year survival at 5% was considered great, and I don't think anyone was making it more than 5 years in these cohorts. But it's interesting, it's not just 3-year survival, it's 3-year, the majority of these people actually have progression-free survival. So they're like Brad. If you kind of just look at the top 30%, so if you look at the top 30 versus the bottom 30, there's this one, of the 330 patients, the top 100 patients, their estimated survival, their kind of predicted survival is almost 60 months. So that is almost 5 years for median survival. And when we compared it to other types of trials that have been done, the standard of treatment, which is the Stoop protocol, the prognostic factors were all very similar. And then this is kind of the survival rate. So the 3-year survival with standard of care was 16%. And these trials failed, because they did not show an increase between controls and treated. Although if you look at the 2-year survival rate, there was an increase, and I'll explain some caveats about clinical trial design as to why that potentially could be. But Optune, which is actually an FDA-approved device, actually has a 3-year survival of 26%, whereas this trial, actually the intent to treat population is 28%. So that's actually the control and the treated. So if you kind of imagine, if you take that whole population, hopefully the treated would be higher, but we actually don't know that yet. But interestingly, now we kind of looked at, well, why did some people, live so much longer? And, one of the things that many of you may know, MGMT methylation does suggest a better prognostic response and better survival for these patients, better prognostic response to temozolomide. But they also tend to do very well on these immunotherapy trials as well. So if we stratified out MGMT methylated, there's a 3-year survival of 49%. So almost half of these patients are in that methylated group are living to 3 years. And if you're unmethylated, you're a little closer to what the standard protocols would be. So it could be that in the future we would stratify people with certain markers to get immunotherapy, and people without those markers to get something else. And that's probably what's going to evolve into the future. And I think one of the problems with our immunotherapy trials is that the response rate is usually about 20-25%. So if you take two groups and you look at median survival, which is usually kind of what the cutoff is, some difference in median survival, if 50% of the patients have no response, then that median survival won't be any different between control and treated. So I think there's going to be some changes in the way we think about how we approve these treatments based on that. So with that, we've been working on various clinical trials to kind of enhance this effect. So we do have an upcoming clinical trial where we actually are going to be using this vaccine in combination with a checkpoint inhibitor. That should be opening in the next couple months. And this just kind of illustrates the timeline it takes to get something to that point. we did the first in man dendritic cell vaccination for glioblastoma back in the late 90s, and then did the phase 1, clinical trials. This is kind of when Brad was enrolled. We've been following these patients for 16 or plus years now, and now we finally we completed enrollment of the phase 3, and now we're going to combination trials starting in the next couple months. Other clinical trials we have at UCLA, we do have a gene therapy trial, and some of you may have heard the tocogen virus, the toca virus, and what it is actually, it is a replicating competent retrovirus, and basically it's injected into the tumor after resection, or for an unresected tumor, it's injected in there, and then patients, the virus theoretically gets into only dividing cells. So the tumors divide. Unfortunately, your brain cells don't divide that much as an adult. Once the virus gets in, then you treat it with basically an viral drug, an antibiotic, to kill off the virus, but with the cells within them. So in terms of the timeline for this is actually also a therapeutic developed at UCLA. Nori Kasahara developed this in 2009, or in the mid-2000s when he was at UCLA, and actually we were the first to inject this into humans. And then that's gone on to phase 1, phase 2, and now phase 3 trials for this particular therapeutic. And then the future iterations of this will probably include this virus with also immune modulators. Because one thing we're finding is that viral therapy or gene therapy is actually really immune therapy. The long-term survivors in those trials, whether it be the toca virus, the polio virus, all these different kind of viral therapies that you may be hearing, it turns out that they are getting an immune response to the virus, and that's probably what's dictating their long-term survival. We also just recently, Tim Clausey, who's our neuro-oncologist, and our group recently published a paper in Nature Medicine just last month on the use of these checkpoint inhibitors. And another concept that came out of this recently is that the timing of treatment makes a difference. So this was just a very simple study. It was using one drug, nivolumab, it's a checkpoint inhibitor, and the two arms, the difference between this arm and that arm was just the timing of when you gave it. So basically one group got the checkpoint inhibitor before surgery, and one group got the checkpoint inhibitor after surgery. So one group got it before and then after, meaning neoadjuvant and adjuvant, and one group just got adjuvant. These checkpoint inhibitor trials have been done previously, and they actually all failed as a single agent for glioblastoma. But it did seem to extend survival if you did it before surgery. And the reason we think immunologically that is because you actually need the antigen present in order to induce an immune response. So if you take the tumor out before you induce the immune response to the tumor, you actually don't get the effect. So that's why giving it before surgery, while you have the tumor there, to induce your immune response, your T-cell response, and then giving it subsequently after actually makes a difference. So this is kind of renewed interest in these kind of checkpoint inhibitor and immunotherapy trials. So it kind of, for a while when all those trials failed, people used to think, well, they're not going to work for glioblastoma. I think they can work. It's just a matter of timing, and also maybe some of these need to be used in combination with vaccines, because one thing the vaccines do is they get the T cells in the tumor. So that's the whole concept of getting a cold, what they call a cold tumor, non-immunogenic tumor, to a hot tumor. And our group was also very instrumental in kind of getting this to kind of this renewed clinical trials with these drugs. And then another thing that I think, UCLA's really made an impact on are, this other category of glioblastomas with the IDH1 mutation. The IDH1 mutation IDH1 is an enzyme in the Krebs cycle for, if you remember biology. And it was actually a mutation that was found in glioblastomas in 2009, so it was relatively recent. We and a company called AG Palagios also in 2009 discovered that these IDH1 mutated gliomas secrete a metabolite called 2-hydroxyglutarate. And then based on that, we've actually, gone on to do, again, phase 1 clinical trials with this drug. And this is kind of what those trials have shown. Basically, these are more the non-enhancing low-grade tumors because the IDH1 mutated gliomas tend to be lower grade, or the secondary glioblastomas. So these drugs just show that if you take a non-enhancing tumor, give the drug, you actually decrease the growth rate of the tumor. So it doesn't make the tumor go away. It's not cytotoxic, but it's potentially cytostatic. So for a low-grade tumor, I guess the benefit of this is that in the future you may be able to avoid radiation for these low-grade tumors, which typically do occur in younger patients. And you heard from Dr. Kim what the kind of long-term potential neurocognitive effects could be for radiation. So with that being said, I'm sorry the writing is so light, but there's some websites that you can go to if you want to learn more about our clinical trials. And then just do want to end with this kind of statement that now, because the tumor tissue is so important for deciding what to do after surgery, it does make a difference, how you save the tumor tissue and what you do with it. Sometimes we use it to make the vaccine, so we actually need the actual tumor tissue fresh at the time of surgery. But there are a lot of trials that don't necessarily need the tumor fresh, but what they do need is the genomic analysis of the tumor and the genomic sequencing. And at UCLA, we do all, we have someone who comes down to the OR 24/7 to collect tumor tissue for this purpose. But if you're in the community and you don't have that, there are these commercial places that do this. Foundation Medicine actually does genomic sequencing, and Caris does, and these are now becoming paid for by insurance. So this is something that I think a lot of patients are going to be asking for, and probably in the future it'll be pretty standard. So thank you for your time.